हेलो एंड वेलकम टू प्रोफेसर गाडगिल जीपैट एकेडमी। जीपैट में फार्माकोलॉजी से हर साल इंसुलिन पर 2 से 3 क्वेश्चंस आते हैं, लेकिन स्टूडेंट्स कंफ्यूज करते हैं कौन सा इंसुलिन कब काम करता है, किसका पीक कब आता है, कौन सा आईवी दे सकते हैं। आज इस वीडियो में मैं तुम्हें इंसुलिन टाइप्स और ओरल एंटीडायबिटिक ड्रग्स कंप्लीट स्ट्रक्चर्ड निमोनिक्स के साथ समझाऊंगा। अंत तक देखना। First, we will discuss the basic pharmacology for the insulin. The source is human insulin via the rDNA technology or the analogs, that is modified amino acid sequences. The route usually preferred is subcutaneous, which is the main route, and regular insulin can be given IV. Storage is 2 to 8 degrees Celsius as it should be refrigerated. In use vial or pen at room temperature for 28 days can be kept. Goal is to mimic the normal physiological insulin secretion, that is basal plus prandial. Now we will discuss the detailed profiles. First is the rapid-acting analogs, that is Lispro, Aspirant, and Glargine. Key features is that they have the monomeric structure and hence rapid absorption. Dosing should be immediately before or after meals 5 to 15 minutes prior. Advantage is that it has better postprandial glucose control and less late hypoglycemia. It can be given via insulin pump, that is continuous SC infusion. Second is the short acting, that is the regular insulin. It forms hexamers and hence slow absorption. Dosing is 30 to 45 minutes before meals. Special use is that it is the only insulin type approved for IV infusion, decay, hyperkalemia, and critical illness. Disadvantage is that delayed peak and hence risk of between meal hypoglycemia. Third is the intermediate acting, that is the NPH, neutral protamine hagedron. The key feature is that protamine is added to delay the absorption as it can form crystals. Dosing is usually twice daily before breakfast and bedtime. It must be resuspended via rolling gently and should never be shaken as it can create bubbles. Peak issue is the pronounced peak around 4 to 8 hours and can cause nocturnal hypoglycemia. Fourth is the long-acting analogs, that is Glargine, Detmer, and Degludec. Glargine forms the microprecipitates at injection site, flat profile and 24 hours duration. It should not be mixed with any other insulin because of the pH dependency. Detmer binds albumin and has prolonged action. It should be given twice daily and often needed for full 24-hour coverage. Degludec forms the multi-hexamers and hence is ultra-long, that is 42 hours. There is flexible dosing and dosing can vary by plus minus 8 hours. Last is the premix, that is biphasic insulin. Combinations include NPH plus regular or protamine crystal plus rapid analog. Examples are 70 by 30, that is NPH plus regular, and 75 by 25, that is protamine Lispro plus Lispro. Advantage is of conveniency and hence fewer injections are needed. Disadvantage include inflexible, that is fixed ratio, cannot adjust basal or bolus independently. Next, we will discuss the general guidelines for the regimen and indication. For basal only regimen, indication is mild type 2 once daily long acting. For basal bolus regimen, indication is type 1 and advanced type 2 most physiologic. For premix BID regimen, indication is type 2 with regular schedules and elderly. For sliding scale regimen, indication is hospital inpatient only and not for home. Critical guardrails include regular insulin, the exclusive insulin approved for IV infusion, decay and critical illness. Glargine isolation, never mix with other insulins, it is pH dependent and hence mixing causes precipitation and loss of effect. Next is the NPH handling, that is cloudy insulins must be gently rolled, never shaken to prevent the air bubble formation. Now we will discuss the oral hypoglycemic agents. They are used in type 2 diabetes mellitus when lifestyle modification fails and are often combined with each other or with insulin. Major classes includes biguanides, which act by decreasing hepatic glucose production. Sulfonylureas increase the insulin secretion. Meglitinides rapid increase insulin secretion. Thiazolidinediones increase the insulin sensitivity. DPP4 inhibitors increase the GLP-1 SGLT2 inhibitors block the glucose reabsorption in kidney, and GLP-1 agonists increase the GLP-1 receptor activation. Next, we will discuss the detailed drug profiles. First is the biguanides. They activate the AMPK and hence decrease the gluconeogenesis and increase the glucose uptake in the muscle. Advantages include no hypoglycemia, weight neutral or weight loss, CV benefits, and inexpensive. Adverse effects include GI, that is diarrhea, nausea, bloating, and hence start low and go slow. Rare lactic acidosis, risk if renal failure, hypoxia, or alcohol. Contraindications include eGFR less than 30 ml per minute, unstable CHF, severe liver disease, and metabolic acidosis. Note: hold 48 hours before IV contrast, as there is risk of lactic acidosis and hence restart after normal renal function. Next class is the sulfonylureas. They bind to SUR1 receptor on the beta cell, close the K-ATP channel, causing depolarization and resulting in calcium influx, causing insulin release. Examples include glimepiride, glipizide, and glyburide. Adverse effects include hypoglycemia, weight gain, sulfur allergy, which has cross-reaction possibilities. It should be avoided in elderly, renal or hepatic impairment, and irregular meals. Meglitinides act same as sulfonylureas but shorter duration of action. Dosing: it should be taken 15 to 30 minutes before each meal. Advantage is that lower hypoglycemia risk than sulfonylureas. Examples include repaglinide and nataglinide. Thiazolidinediones, they act on PPAR gamma, causing increase in the insulin sensitivity in fat, muscle, and liver. Examples include pioglitazone and rosiglitazone. Adverse effects include fluid retention, weight gain, fractures, and bladder cancer. Slow onset, takes weeks for full effect, and contraindications include NYHA class 3-4 heart failure. Next class is the DPP-4 inhibitors. They inhibit the DPP-4 enzyme, that is, GLP-1 and GIP levels rise, and hence glucose-dependent insulin secretion and decrease in the glucagon. Examples include sitagliptin, saxagliptin, linagliptin, and alogliptin. Advantages include weight neutral, no hypoglycemia, and well tolerated. Adverse effects are rare pancreatitis, arthralgia, and nasopharyngitis. Weakness: modest A1C reduction, that is 0.5 to 1%. Next class is the SGL2 inhibitors. They block the SGL2 in the proximal tubule, causing the glycosuria, that is glucose in urine, osmotic diuresis. Examples include empagliflozin, dapagliflozin. Advantages: weight loss, BP reduction, CV mortality reduction, and slows CKD progression. Adverse effects include genital mycotic infections, UTI, polyuria, euglycemic decay, lower limb amputation. Contraindications include eGFR less than 20 to 30, varies by drug, and prone to decay. Next class is the GLP-1 receptor agonists. These are injectable and not oral. Examples include liraglutide and semaglutide. They increase the glucose-dependent insulin, decrease the glucagon, and slow gastric emptying time and satiety. Advantages include weight loss, CV benefit, and low hypoglycemia. Adverse effects include nausea, vomiting, diarrhea, rare pancreatitis, gallbladder disease, medullary thyroid cancer risk. Contraindicated if MEN2 or family history. Oral semaglutide is available and requires fasting 30 minutes before. Next, we will discuss the therapy or choosing the therapy. For first line, metformin is preferred if tolerated. For ASCVD, that is heart attack or stroke, SGL2 inhibitor or GLP-1 agonist are preferred. For heart failure, SGL2 inhibitor are preferred. For CKD, SGL2 inhibitor or GLP-1 agonist are preferred. Weight loss needed, then GLP-1 agonist or SGLT2 inhibitor are preferred. avoid hypoglycemia, then metformin, DPP-4I, SGLT2I, GLP-1 agonist, and TZDs are preferred. For cost or access, metformin or sulfonylureas are preferred. Next, we will discuss the combination therapy. Metformin plus sulfonylurea is old standard and synergistic. Metformin plus DPP-4I rational is weight neutral and low hypoglycemia. Metformin plus SGL2I rational is weight loss and CV or renal benefit. Metformin plus GLP-1 agonist rational is best for weight loss plus CV benefit, and metformin plus basal insulin rational is late stage 2 diabetes mellitus. Next, we will discuss the blueprint of glycemic targets. Biguanides, that is metformin for hepatic anchor, meglitinides for rapid pancreatic squeeze, sulfonylureas for prolonged pancreatic squeeze, thiazolidinediones for systemic sensitizers, DPP-4 inhibitors for incretin enhancers, and GLP-1 agonists for satiety and weight loss. That's all for today. Thank you.